Okay, I think we're ready to start. Thank you so much for joining us for our webinar, Game-Changing GLP-1 Obesity Medications. Exciting breakthroughs, but challenges remain. My name is Kathleen Prasnowski, and I am Director of Development for Feinberg School of Medicine. And in that role, I'm fortunate to work closely with Dr. Kushner. We are all in for a great treat today as we learn more about this fascinating and emerging landscape. I'm pleased to introduce Dr. Robert Kushner. Dr. Kushner completed his medical degree at the University of Illinois, his residency at Northwestern, and his fellowship at the University of Chicago. And we have been lucky to have him on our faculty for the past 27 years. A world-renowned expert in the field of obesity, Dr. Kushner is a professor in the departments of medicine and medical education. And he is the former medical director of the Northwestern Center of Lifestyle Medicine. He was also the corresponding author for the Step 1 semaglutide trial that was published in the New England Journal of Medicine in 2021. A few housekeeping things. We've got a great group today of medical school alums, as well as some friends of Northwestern. We hope you enjoy the presentation. We'll have Q&A following the remarks, and we really appreciate all of the questions that have been submitted in advance. You may also submit questions during the talk using the Q&A button at the bottom of your screen. We'll try to get to as many as possible. Also, closed captioning is available if you click on the CC button below. Thank you so much again for participating. And now I will hand it off to Dr. Kushner.
Thank you, Kathleen, and thank all of you for joining today. Let me go ahead and share my slides. There we go. And hopefully everyone will be able to see that. I am so pleased to be here today to go over what has become an exciting area, not only in medicine, but also in our society. It has certainly been the most exciting breakthrough in my career over 40 years in the obesity space. So I hope to give you all a background on what GLP-1 is, how do we use it as a medication, what can you expect, what are the outcomes, and then end it with challenges that this new therapy has actually brought forward. And these are some of my conflicts of interest. I do work with pharmaceutical industry as a consultant. I want to start off with a few comments about obesity, kind of to set the ground for everybody. Today's talk is not about trying to get people thinner or just from cosmetic point of view because someone is living in a larger body, although it certainly can be important for someone to be treated at that. But it's really thinking of what obesity is as a medical condition. And by one estimate, by 2023, more than 1 in 2 adults will be living with overweight or obesity. Currently, that's about 75% in the United States. And as I mentioned, it's not simply a cosmetic issue that we're talking about. It's obesity as a chronic disease. And what's listed in these figures of a male and female are some of over 200 complications, or we call comorbidities, that have been associated with obesity, including fatty liver disease, arthritis, type 2 diabetes, coronary artery disease, hypertension, and sleep apnea, and so forth. And these are the types of patients that I would typically see in my Center for Lifestyle Medicine. And I'm sure many of you on the webinar today either have some of these medical problems or certainly know people that have some of these medical problems. Now, I've mentioned that obesity is thought of as a chronic disease. And what I'm showing you here are statements from multiple organizations and societies from around the world, from the World Obesity Federation, Obesity Canada, American Medical Association, and so forth. And I put in yellow the commonality of how all of these organizations and societies view obesity. And it's primarily a condition of excess body fat, so that's what obesity is. But it's not just excess body fat, it is also associated with medical problems. In other words, it's excess body fat that's causing harm to your body. And that can either be a gateway to other medical problems or chronic disease itself because of how fat is deposited in the body or dysfunctional fat. So this is the condition that we're talking about, and I'll be referring to today. So for the agenda for the talk, I've divided it up into two parts. The first is game changer, and I'll show you where that name came from in just a minute, and then end up with part two, which is what challenges does this actually present? So part one is game changer. Kathleen mentioned to you that everything changed in 2021 with a publication I'll mention in a minute. But in the world of obesity, of course, we're trying to help people become healthier. But part of the way we help people living with obesity to achieve improved health is to help them lose weight. In other words, to lose that excess body fat. And this is what obesity treatment looked like before 2021. What I'm showing you is increasing percentages of weight loss from 0 on the left to 35% on the right. And the interventions that we had available to us just 5 years ago. If you look towards the left, lifestyle treatment on the average results in about an 8% weight loss. If you add what we call a first generation medication, these would be oral medications. Phentermine will come to mind, Contrave, Qsymia, if any of you are familiar with these medications. They're oral tablets that work up in the brain, and you can boost weight loss up to about 10%. And then you go to the other side, which is on the right, which is bariatric surgery. Clearly the most effective treatment we have, even today, for at least how much weight one can lose. Now you're talking about anywhere from 28 to over 35% body weight. What that left is a treatment gap. And that is if I saw a patient who would benefit from losing more than 10% of their body weight, but was not interested in or had a contraindication to bariatric surgery, I was not left with very many treatment options. That treatment gap was filled in 2021. And this is the 2021 article that Kathleen mentioned in New England Journal on the first publication of the drug called semaglutide, which is a GLP-1 medication. And as you see, because I underlined it just for easy viewing, I was the corresponding author on this article, which led me to a whole lot of interviews and so forth. And I just put up here some of the headlines that were posted in 2021. Injected drug delivers up to 20% weight loss in trial. Towards the left, a game changer. Drug brings weight loss in patients with obesity. That's from the New York Times. So that's where that game changer moniker came from. Obesity medication almost doubles the amount of weight you can lose. So this got play not only in the United States, but since this drug, the company is global, it got headlines everywhere around the world. And let me just show you with this one graph how impactful the delivery of this GLP-1 drug called semaglutide was when I compare it to other drugs. What I'm showing you here is a figure of all the drugs that are available for treatment of obesity. If you look across the top, we have orlistat, which is taken to block dietary fat. The next one is phentermine topiramate, which is Qsymia, naltrexone, bupropion, Contrave, and liraglutide or Saxenda. These are called first-generation medications. And below it are the trials that are done. They're called randomized controlled trials, about 1 year in duration, where individuals, on average, how much weight you lost, either taking a drug, which is in dark purple, or light purple is placebo. And I'm going to put a dashed line at 10%. Kind of makes it easier for the point I want to make in a moment. But prior to the delivery of the semaglutide 2.4, which is called Wegovy, you can see that individuals on the medication are able to lose in controlled trials 10 to 12% of the body weight. That's a lot of weight, but that's where we were stuck at. And then Wegovy or semaglutide came out, and you could see how it really blew past that dashed line. Now you're losing 15 to 17% of your body weight. And lo and behold, 2 years later, tirzepatide, the trade name is Zepbound, also Mounjaro for diabetes, Now you're losing 20 to 25% body weight. So you can see how clinicians and the media were excited about this just by looking at how much weight loss this drug caused compared to previous drugs. And I'm going to show you one other way to look at it. And here at the bottom are the drugs I just showed you: orlistat, phentermine, topiramate, naltrexone, bupropion, and so on. I'll just put a circle around the two I want you to look at, which is semaglutide and tirzepatide, which harness this GLP-1 drug. And what you see here is the percent of people losing weight on this drug. And let me just normalize this for you. So on semaglutide, 32% or 1/3 of individuals on semaglutide, if you start out weighing 200 pounds, you're losing 40 pounds on this drug. And if you're on tirzepatide, which is Zepbound, and you look at 25% weight loss, if you start off at 200 pounds, you're losing 50 pounds. So this is, significant, highly effective medications that we have never seen before. So I've been in this field for 40 years, and this is the best graph I can find that tells you how I feel as a clinician, investigator, and academic professional. We are at an inflection point, and the Y on this thing, it was in 2021, and we're on this rapid upslope going to Z regarding the development in this field of obesity. And if you look at the biggest health and medicine stories of 2023 from Scientific American, it was weight loss drugs along with CRISPR gene editing. If you don't know what CRISPR gene editing, that is when you could take someone living with sickle cell disease and alter their genes to cure their sickle cell. It was on the same par regarding the excitement as something like that. So it's this upswing. And if I try to interpret why is this such an inflection point, I come up with four reasons, and I'm going to go over these with you today. One is increased effectiveness of medications. And I already showed you how much more effective these medications are. So that's number one. Number two, more acceptable delivery of the medication. So if any of you are on these medications or know people taking them, it's a once a week auto injector, self-administered medication. So once a week for about 45 seconds, you do an auto injector, and that's the treatment or the dose for the entire week. And that is very acceptable. So that's a game changer. The third one is a changing paradigm in a treatment target. And I'm going to explore that with you, starting with the next slide. And that is, being in this field for 40 years, we did not have an active target that really treated obesity effectively. And the best comparator I could think of is every day on TV now, if you're watching commercials, it's one biological medication after another for Crohn's disease, rheumatoid arthritis, ulcerative colitis, other skin diseases, and so forth. And these are called biologics. And they found the target that linked all these rheumatologic and inflammatory diseases. And it's a huge spread of medications that are being developed called biologics. Well, this is the equivalent of biologics for obesity. We finally found a target that is so effective, everyone is now exploiting it. And I'm going to explain what that is in just a moment. And lastly, it's a game changer because of what we call pleiotropic effects of these medications. Pleiotropic, if you're not familiar with this, is multiple organ outcomes. So this drug has effects in multiple targets. That's pleiotropic. And I'll show you exactly what that's all about in a minute. So let me start off with what I mean by paradigm shift in the treatment of obesity. And that is by attacking or targeting the gut-brain axis with these hormone-based therapeutics, we are able to crack the nut regarding how to really help people get healthier through weight loss. So let me show you that. This is an anatomical figure. You don't have to memorize it, obviously. But what it shows and why I chose to use this is, one, it's a picture of the brain. And obesity is in large part a problem within the brain in which an individual may not be perceiving these signals from the periphery, which comes from fat tissue and the gut. So again, to reinforce this, to show how it works is that signals come from the gut, the intestinal tract, and the adipose tissue or fat tissue, send signals to the brain. And that's when you start feeling full, hungry, you're enticed with food, you're thinking about food, you're having cravings. That all comes from the brain. And the brain gets signals from the gut regarding, am I hungry? Am I full? Am I content? And so forth. Here's the current thinking about obesity. And that is probably not all people living with obesity, but the one that's been investigated the most is that people predisposed to developing obesity or gaining weight have a dysregulation of signaling to the brain from the gut, particularly these hormones, which I'll go over a little bit more. Here's GLP-1 right there for you. And the appetite cues are enhanced regarding fullness, which is muted, and hunger, which is amplified, which leads people to consume more food than they normally would because they're not getting normal signals. That then leads to expansion of body fat that exceeds healthy body fat storage. That's in a nutshell. Hundreds and hundreds, if not thousands, of articles in the literature. There are probably many, many other biologic causes of obesity, but the one that we have explored the most is a miscuing of signals that's telling someone, I've had enough to eat and I don't need to eat anymore. And I'm showing that here in a more simplified form that on the left, at the bottom left, are these hormones from the intestine. Here's GLP-1, GIP. Those are the two we're going to focus on the most. And all of them tell you you're full. They're called satiety hormones. One hormone increases hunger. It's called ghrelin. These signals, which occur after eating and so forth, come up to the brain in both the hunger center and the reward center. And if you're not getting these signals properly, you're going to have increased hunger, you're going to have reduced fullness and less contentment between meals, and increased cravings and thoughts of food. So that's what happens when these signals are not actually received adequately. But what happens if you actually treat individuals with what we called hormone-based medications? And the two hormones that have been isolated and used for treatment, I circled it at the bottom right for you, is GLP-1 and GIP. These are naturally occurring hormones in the intestine that we all have. But if you take these, synthesize them, and give them back as a medication, which I'm showing you on the bottom right, and give GLP-1 back as a pharmacologic dose, that the drug name is semaglutide, trade name is either Ozempic or Wegovy, or combine GLP-1 and GIP together. Again, these are naturally occurring hormones. You synthesize them and give them back to people as an injection. The combination of GLP-1 and GIP, tirzepatide is the generic. The trade names are Mounjaro or Zepbound. You then get adequate signaling and you change these feelings here to reduced cravings and thoughts of food and reduced hunger, increased fullness, and more contentment between meals. So it's not that individuals living with obesity are deficient of these hormones. The current thinking is that the level of hormones are insufficient to affect appetite. And those individuals do better when you give those higher doses through medication. And I'm just showing you one CAT scan or a CAT scan of the brain just to show you that if you give GLP-1, you it not only affects the hunger center, these are areas in the brain that light up when you give GLP-1. In the hunger center lights up and the reward center lights up. So these medications are getting in the brain to affect appetite. So that's how these medications work. They don't contour the body. They don't burn fat locally. They don't reposition body fat in the body. They work in the brain to affect appetite to get the signals that we're missing. And therefore, appetite is reduced, caloric intake is reduced. Hopefully, one is eating a healthier meal and they're then losing weight. So I'm going to read this to you because this is mind-blowing and this is fundamentally changing the way we're thinking about obesity. I think it will be for you. It's a new way to think about obesity. Obesity results from genetic and environmentally driven dysfunction of normal body fat regulation. That's basically what I just told you, is that there's a biology to it and people are not getting signaling. That leads to elevated body fat. The bottom two phrases are incredibly important. Overeating does not cause obesity. Obesity causes overeating. The disease of obesity causes overeating. So you get into this vicious loop. Undereating does not fix obesity. Fixing obesity leads to undereating. And that's what I just showed you. If you actually treat the biologic cause of obesity, this appetite dysregulation, you then can help someone eat less food and then you lose weight. You don't treat obesity by telling someone to eat less food. You're working against biology. All right, so now that's the background. Let me go you through with you now. What have we learned about these drugs? So these are two seminal studies. On the left is semaglutide. That's the one that I participated in, New England Journal. The second is the tirzepatide. That's Wegovy on the left and Zepbound on the right. And what you could see is the weight loss is very dramatic, about 15% weight loss after 68 weeks and over about a 22% or 20% weight loss after 72 weeks with semaglutide. And notice the curve. If you start on this drug, either one, you lose weight fairly quickly, and then it starts to plateau when you get out to about a little over a year. On the bottom are these categorical weight losses I mentioned before, such that 1 out of 3 individuals on semaglutide is losing 20% of their body weight, and 1 out of 3 individuals on tirzepatide is losing 25% of their body weight. But there is heterogeneity, there's variation in response. So I can tell a patient, on average, you'll lose 15% of your body weight on semaglutide. However, you may end up losing less than that or more than that, depending upon your own biology and how you respond. One other point I want to make out of these figures is that with semaglutide, up to 14% of individuals did not lose at least 5%, of their body weight. I call them unresponsive. That's probably not a great term. It's just their body did not respond as much as we would like it to. And that lack of response is about 1 in 10 with tirzepatide. So not everybody responds. I could tell you it's one of the most frustrating things I see in patients as well as a clinician, because you hear so much about how wonderful these drugs are. You could be a non-responder, and we don't understand exactly why that is. Now, there are many other benefits of these drugs. I told you up front, this is not about just cosmetic and aesthetic use of these drugs. It's to help people get healthier. And I just wanted to show you the results after 2 years of a trial with semaglutide. Waist circumference was reduced 14.4 centimeters. Now, many of you probably don't know what that is because we don't use metric. That is the same as 5.7 inches. That is equivalent to changing your belt almost 6 notches. Each notch is 1 inch on a man's belt, at least. So you can imagine you take your belt, go 6 notches in. That's the change in your waist circumference with these drugs. That's really quite dramatic. Blood pressure goes down, systolic and diastolic, and this is an inflammatory marker called C-reactive protein. We also see reductions in hemoglobin A1C. These are people without diabetes, but yet hemoglobin A1C or A1C, many of you are probably familiar with that, as a screening marker for diabetes as well as following someone on treatment. It dropped almost 0.5%. Plasma glucose went down as well, and insulin and triglycerides went down 19%. So these are just some of the benefits of losing weight that we think about every single day. Now, there are 2 other trials I want to go over with you because this is so important to emphasize 2 points. One is what happens when you stop the drug. Number 2, to emphasize that obesity is in large part a biologic disease. And let me walk you through these 2 studies. They were done exactly the same. One was semaglutide on the left, tirzepatide on the right. They did the exact same study, which is really great to reinforce concepts. And what both of them did is they took individuals in research projects like we do at Northwestern and other research sites, and you have volunteers come in who are living with overweight or obesity, and you give them a medication called open label. They all knew they were getting a medication. So with semaglutide, for the first 20 weeks, they got open label semaglutide. They knew they were getting the drug. with tirzepatide. It was open label. They got it once a week out to 36 weeks. So at that point, at 20 weeks or 36 weeks in these two drugs, individuals, and they signed consent for this, they knew this was going to happen. At this point, they were then blindly randomized to either continue on the drug or blindly randomized to going on placebo. They didn't know what they were going to get, neither did the investigators. Now, if any of you have been in a research study, which if you have, thank you for your service. But people who volunteer for research do it for many reasons, one of which is to get healthier and to get the benefits of it. And these are individuals who are just rocking it. They are proud of themselves. They're all losing weight, as you see. They're your best research subject. Everyone around them, their family and friends and coworkers, and congratulating them. They're looking wonderful. Thank you for volunteering and so forth. And they know they have to stay in the trial for another out to 1 year. But they don't know if they're getting the drug or not. And they're following a lifestyle program. They're coming in, seeing the investigator. They are your best research subject. Let me show you what happens to their body weight. And the only thing that changed is either they continued on the drug blindly or they continued on placebo blindly. And in both studies, those that continued on the drug continue to lose weight out to 17% body weight or 22% body weight. And look at what happened on those switched to placebo. They didn't know they were on placebo. They were unable, on average, to keep the progress going, and they gained weight out to the end of the study, as you see in both of these. So this says two things. One is the benefits of the medication generally or will not last if you stop the medication. It's like having diabetes and you get your hemoglobin A1C down and you say, okay, my diabetes is under control. I can stop the drug now. I think most of us would say, well, that doesn't make sense. Your diabetes is going to come back. The obesity came back. Number two is that this, to me, among any other study I've seen, really demonstrates that it's a biologic disease. Despite these volunteers wanting to lose weight, they were motivated. They had lost weight. They're eating healthier. They want to do well. They were unable to keep up that weight loss because they weren't being treated biologically with a drug anymore. So very important take-home message. Now, GLP-1s also have what we call pleiotropic effects, and that is not only affects the brain, which is on the left, which leads to weight loss, but also has effects on the liver, the kidney, blood vessels, atherosclerotic plaques, the heart, and so forth, leading to improved health regarding many, many other medical problems individuals have. And this is a summary of the benefits to date on using GLP-1 medications. Let me start on the right. These are established benefits. Someone with diabetic kidney disease, DKD, will have an improvement or a slowing down of the kidney disease of diabetes by taking these medications. Individuals who had a prior heart attack, have heart failure, or have had a stroke, when they take these medications, they will reduce the risk of having a second heart attack, stroke, or having worsening heart failure or dying of cardiovascular disease. In the middle, we also have evidence for weight loss, of course, we talked about that. We also have evidence of improvement in obstructive sleep apnea, that's ASA. In fact, Zepbound is approved for treatment of sleep apnea in individuals with obesity. In the middle, we have these cardiorenal disorders. MACE stands for major adverse cardiac events. That's a stroke or heart attack or dying of cardiovascular disease. Wegovy has an FDA approval for treating individuals with pre-existing cardiovascular disease and obesity and reduces cardiovascular death, all of this by 20%. And of course, these drugs have been used a long period of time to improve type 2 diabetes. On the left are investigational, which is really very, very exciting. And that is helping individuals with metabolic dysfunction associated steatotic liver disease, or fatty liver disease is known as. Parkinson's disease, Alzheimer's disease is now being studied, peripheral arterial disease. And the one that's not on here, which is also interesting, is alcohol misuse disorder. It used to be called alcoholism. It's not anymore. It's alcohol misuse disorder. Someone has difficulty controlling alcohol intake. So it's just amazing how this drug has so many we call pleiotropic effects. It is becoming incredibly widespread. This is a recent survey. 1 in 8 adults say that they have used a GLP-1 drug either to lose weight or treat diabetes or heart disease. And here you see it's broken up by age group. So as you could expect, the older the age cohort, the greater the percent of using it for a chronic disease like sleep apnea, heart disease, diabetes, and so forth. The younger individual is using it more for weight loss alone. But just think about 1 in 8 individuals have exposure to this drug. That's how widespread and the uptake of this drug has been. Before I get into challenges, I want to say a word about where are we at. We are actually at the beginning of the story, not at the end of the story, the beginning of the story. We would say the end of the beginning, I guess is another way of saying it. There are many new drugs on the horizon. I made the analogy earlier to biologics when it comes to rheumatologic diseases and inflammatory bowel disease and psoriasis and so forth. So this is the equivalent of finding the target. And now let's explore all the hormones in the intestinal tract and combine them and see if we can help people lose weight and improve their overall health. So this is from Nature magazine. It's just a really nice figure. That's why I took it. And what you're looking at is percent weight loss. And I already showed you the results for Wegovy and Zepbound. That is, I believe it's these two drugs here. But there are many drugs on the horizon. There's survodutide, there's retatrutide, CagriSema, Maritide. You don't need to know any of these. But what I do want you to notice is they're combining many other gut hormones. Like here's GLP, survodutide is GLP-1 with glucagon. Retatrutide is GLP-1, GIP, and glucagon. So it's 3 hormones combined. This orforglipron is the very first oral medication that's going to likely get approved based on the studies that are coming out. I suspect if everything goes well with the FDA, you can see an oral equivalent of what I'm talking about regarding the benefits of this drug probably in 1 to 2 years, which would then give patients options of a once-a-week injection, which takes about a minute, or take a daily oral medication. And this is just the beginning of probably 100 different pharmaceutical companies that are working on compounds with these kinds of weight loss. Look at the amount of weight loss, 25% weight loss, and there's no plateauing yet at all with the retatrutide. So let me spend the rest of the time regarding challenges. What does this lead to, and what do we need to be thinking about? Well, first of all, there's a total of nearly 137 million adults that are eligible for this type of a therapy. And this kind of gives the infographic here towards the right. More than half, 52% of all US adults are eligible for GLP-1 therapy based on either having obesity with 1 or 2 medical problems, having obstructive sleep apnea because it's approved for that, or having obesity with cardiovascular disease, and those individuals with diabetes. So those are all the conditions that are currently approved by the FDA. Over half of Americans could potentially do that. This exceeds the number of adults eligible for statins like atorvastatin, rosuvastatin, which is 82 million. So just think about that. How many people are going to be on this medication, and can we actually produce enough of it? However, how long do people really stay on this medication? I showed you data from trials, 1 year trials basically. But if you go into the real world, they're called real world experience. In one of the studies that was published this year, 53% of GLP-1 users discontinued the medication by 1 year, and 72% discontinued by 2 years. It talks about a higher income was associated with a lower rate of discontinuation. Those with diabetes tend to stay on it. Some people certainly go back on the medication. And on the right here is the proportion discontinuation rate. It continues to climb over time. Now, this study is not able to tell us why are these individuals stopping the drug. Reasons I think would what you would guess would be lack of insurance coverage, it's not affordable out of pocket. They change jobs and therefore their insurance doesn't cover it anymore. Side effects, they don't tolerate the side effects and they're not really guided to do so. Just frustration, get tired of doing a weekly injection, or feel that their obesity is under control and they don't need to take it anymore. So those would be reasons I would think of, but I don't know exactly why these individuals do it. So I mentioned before what happens when you stop the drug. And then some of you may be saying, gosh, if I'm on the drug a long period of time and I learn new habits and I learn new ways of eating and new patterns of eating and portion sizes and I become physically active, I got this. I can get off the medication. I got it. And I want to show you a result of a recent study that was published just last year. This one with tirzepatide, in which individuals with prediabetes were on the drug for 3 years. So I'm showing you here percent weight change on the left. On the bottom are weeks since randomization. This goes out to 3 years now. Placebo, they didn't lose a lot of weight, but they lost more than when they started. And there's 3 doses of tirzepatide were studied, 5, 10, and 15. And you can see they lost, 20, 24% of their body weight. And weight is as stable as can be. These people they got it. They understand the behaviors they need to do. It's a habit now for sure. It's got to be a habit. I think I can go off it. Well, the study was stopped, and what you see is the last parts here is they followed these individuals for 7 more weeks off the medication. And look what happens even within 7 weeks off of the medication. On average, look what's happening to the body weight gain. Again, reinforcing that it's a biologic disease. And yes, there's habit formation. There's all kinds of behaviors that are required. And I'm a lifestyle management guy myself. But if you have an underlying medical problem that is treatable with a medication and you stop the medication, just like diabetes, hypertension, high cholesterol, it's a high likelihood the disease is going to come back. And I think that's frustrating for a lot of people. They have to get their head around that. But this is what the studies show. And that doesn't mean no one can get off the medication. And during Q&A, we could talk about, where are we at regarding studying. That's a good question that we could discuss. But the data shows that at least suddenly stopping the medication, because in all these trials, medication was stopped suddenly, people regained weight. Here's another challenge, the cost. This is killing us regarding healthcare insurance, out-of-pocket payment. And what I circled here for you is the launch price of Saxenda, which I didn't talk about with you, but I did talk about Wegovy and Zepbound. This is per month. This is unattainable by the vast majority of individuals here and around the world. So something has to be done. That's one of the biggest challenges about these medications. And I thought you'd find this interesting. The variable global pricing for GLP-1 meds. This is what it is in the United States. Again, the price I showed you is kind of the retail price, but our pharmaceutical managers and so forth, healthcare plans negotiate a price. So it's often lower, like $800 a month. But look at the prices from around the world. USA is where these companies make their money. And it's something has to be done. But that's interesting to see that isn't globally the same price. Because the price is so high, insurance companies are not having a problem covering it. And this is one of my patients brought this into me. I'll just highlight it without taking up a lot of time. This is the letter my patient got from her health plan. We made the difficult decision to discontinue coverage for GLP-1 drugs for weight loss under the health plan. Unfortunately, our projections showed double-digit percentage problems. It was a choice between maintaining coverage for hundreds of employees versus just treating a few. We chose to focus on affordability. And then you end up with, please note that these drugs will remain covered to treat diabetes. So interesting, they're both diseases. Obesity causes diabetes. Diabetes doesn't cause obesity. So if you really want to treat the root cause of all these problems, it's obesity. But they chose to not treat obesity. They chose to treat diabetes. Despite that, this is the best. Premiums for the company's health plan will still be increasing despite dropping coverage for obesity medications in 2024. So this is probably one of the biggest challenges we're facing is how we actually going to afford this. There are strategies that are going on now, and I bet you're all, if you're interested in these drugs, you probably have experienced this. There could either be no coverage at all, which this author said was unethical. There could be lifetime limits. In other words, we will give you the drug that is meant to be taken for the rest of your life, but we'll only give it to you for 6 months, and then you're off it. And I showed you all what happens when you go off the drug. This author felt that was also unethical. There could be a tiering system. I'll show you what that means in the next slide. There could be a subscription model, so it only covers a few medications and not others. And then patient regulatory reform, and that is bringing the prices down. This author felt it could jeopardize future incentives to develop drugs. So that would be, of course, the drug companies making less money. And lastly, this author came up. This is Dr. Emanuel. Many of you have probably seen him on TV. Mayor Emanuel's brother, who happens to be a physician, Azika Emanuel. And he suggested with his authors a tiered approach for insurance companies, where tier one is we only give it to individuals with severe obesity, those with diabetes, yeah, where you have the greatest benefit. And then once those are covered, you go to tier two, three, and four. So it's a way of trying to cover it, but doing it in a prioritized fashion. So there are models out there that can be used. And lastly, just some really interesting observations. I don't know, these I guess are challenges, but they're more interesting. And this came out of a research paper that I was able to identify. And it talks about change in grocery spending and quantity of food purchased pre and post GLP-1 adoption. So it looked at different users and shoppers, and you could forget about the actual units here and look more at the figure. And this is the amount spending dollars by these individuals before going on GLP-1 versus going on GLP-1, spending less money, and look at the quantity of foods bought once you go on GLP-1. So it's going to have implications for grocery stores, and that is shown in this survey, and that is shift in eating and drinking preferences. We've been working in this field trying to help people eat healthier for decades and decades, and then you give them a drug, and blue is consuming more of. Individuals on these drugs, according to this poll, are eating more fruits and vegetables, more poultry and fish. So those are in blue, and they're consuming less confections, carbonated sugary drinks, cookies, baked products, alcohol. I talked about alcohol misuse before, salty snacks. You can see the shift in consumer products being purchased with these drugs. So it has an impact on public health as well. And this is also interesting if any of you are in the food industry. Commercial brands are now starting to label GLP-1 friendly or support. So this is Replenza that you can actually add to your food, which is a protein. And Healthy Choice actually adds GLP-1 friendly. This is really interesting, isn't it? And these new products are being launched trying to appeal to the GLP-1 market. So let me just sum it up for you, then we'll go to Q&A. We are at an inflection point and transformative time regarding the management of obesity brought about by the introduction of GLP-1 receptor agonist medications. That's what RA stands for. GLP-1 medications are having a game-changing impact on the treatment of obesity and associated medical complications. And I went over that with you. However, major challenges lay before us. Medications need to be taken long-term to sustain benefits. What's the challenge? How do we get people off medication if we can? Excessive medication cost is unsustainable, leading to less coverage. We clearly need a change in advocacy and regulatory coverage and how these are actually done. Nearly half the U.S. population is eligible for use. Do we really want half the population on this? And lastly, healthcare systems are being overwhelmed by the demand for obesity care, including Northwestern. So I'm going to stop sharing my slides there and welcome questions. Thank you all.
Thank you, Dr. Kushner, for this exciting presentation. I just have to say, out of all the webinars I've done, our questions have been blowing up. So to everyone on this call, I know we will not get to all of your questions you asked today and then the ones that were submitted in advance. So what I think we'll do is, if you're okay with this, Dr. Kushner, answer what we can at 1 o'clock and then quickly have Dr. Kushner write some short answers and we'll distribute it to the group afterwards because there's just so many questions right now. We're not going to get to them all.
Yep.
Here, let's start. Do people with obesity have a deficiency of GLP-1 or any of those other hormones that you mentioned that signal hunger and fullness? If so, why?
Yeah, so I brought that up in my presentation, but I think it is so important to reinforce that. So thank you for the question. I often think about diabetes when I talk about taking a hormone and synthesizing, giving back to people, and it's how you treat diabetes. But and it's very similar because people with type 2 diabetes actually have a lot of insulin. It's just not enough to treat their diabetes. So it's very similar that they're not. We don't think individuals are deficient in it, but it's not enough for one reason or another, which we don't understand, for their brain to sense those hormones. So if you give super doses back in pharmacologic ranges, it's enough to get to the individual's brain to say, aha, I am full. I am content. I am not hungry anymore. I'm not thinking about food anymore. I'm not having food noise anymore. So there seems to be some, we call it dysregulation in these gut hormones.
Okay, thank you. And then we're going to veer into side effects. What are the most common side effects of a GLP-1 and what can you do to reduce them?
Right, great question. I didn't go over that at all, and I'm glad that was brought up. The most common side effects of these medications are gastrointestinal. Nausea, diarrhea, constipation, can have vomiting and heartburn. And these are the predominate the side effects. And because of that, all of these drugs need to be slowly escalated every month. Always start the lowest dose. You give a once a week injection, and then every month, if you're doing okay, you don't have to go up, but if you're doing okay, your prescriber will then escalate to the next step or the next dose onward every month until you get to the dose that you should be on. So that's how we reduce the side effects of the drugs is by slow escalation. We also learned by doing the trials that by paying attention to your diet, you as a user or as a patient can have a large control over these side effects. So what you want to do, particularly over the first 1 to 2 days of your injection, is to eat smaller meals, avoid or reduce the amount of fat or greasy food in your meals. Plan your meal out so you're having, let's say, 3 meals a day. That's a moderate size. Don't skip meals. Keep yourself well hydrated. And lastly, probably don't go out and party over the first 1 or 2 days. Like go to restaurants and go out and celebrate. You're not going to tolerate that very well. So slow dose escalation. Pay attention to your diet. You can get over a lot of those side effects.
Thank you. So now another follow-up with side effects. Are there long-term side effects if you've been on the drug for a while that we should be concerned about? And then another thing is, do you see any differences in side effects between men and women?
Okay, good questions. So these medications, these GLP-1 medications, have been available on the market since 2005. Initially for diabetes, that's where that information comes from, and then later on for obesity. So we think we can combine them all. So we have 20 years of information globally on these medications. And up until this time, no new side effects or unknown side effects have emerged. I will have to mention you can get increased risk of gallstones. You may end up with pancreatitis. You have to be watched for that. There's a newer side effect of a retinal macular degeneration or macular problem with the eye. So make sure you get eye exams. but nothing else seems to be hiding around the corner. So I think we understand how these drugs work, and a prescriber who's knowledgeable will be monitoring you for all of these problems.
Thank you. The next question is
Oh,
about,
oh, you said males and females. I'm sorry.
oh,
So
sorry, yes.
I don't know. I don't know if, yeah, I don't know of any major differences in side effects among males and females. We kind of treat all individuals the same when it comes to that.
And is there any effect that a man might lose more weight than a woman or vice versa when they take the drug?
Yes, so that is different. I was referring to side effects, but when it
Okay.
comes to weight loss, all of the trials show that women in these trials lose more weight than men. So given the same height, the same weight and age and so forth, the women will lose more weight than men. We don't frankly understand it entirely. The two thoughts are is the distribution or the drug dose in a woman is higher than a man because of changes in body composition, but it may also have to do with female hormones or with sex hormones. We don't really understand that, but that's been seen in every trial.
Interesting. So another subgroup someone asked about are young adults and teens. Can they safely use these type of drugs?
So the semaglutide is approved, I believe, down to age 12, if I'm not mistaken. Tirzepatide or Zepbound, I believe, is approved maybe 16 or 18. I'm blanking out on this. But semaglutide is approved, I believe, down to age 12.
Okay, thank you. Now this is about the central nervous system and effects that these type of drugs might have. How do you evaluate and oversee the long-term neurologic effects on cognition and mood?
So, one of the biggest concerns in using obesity medications is the effect on depression, severe depression, suicidal thoughts, suicidal behavior, and so forth. So, all of the trials with obesity medications, individuals are surveyed and interviewed and fill out different instruments regarding suicidal ideation, suicidal behavior, and degree of depression. That's universal. And both semaglutide and tirzepatide, we have looked at, I've been author in many of these articles, that there is currently no signal or sign that these drugs are increasing severe depression, suicidal thoughts, or suicidal behavior. Having said that, the package insert, as well as all clinicians, are always monitoring individuals for their mental health. So that's that. It has not, however, been studied in individuals with schizophrenia, severe depression, bipolar disorder, and so forth. So these individuals are often excluded from these trials. So that's a whole nother area that we need to study because there's many individuals that would benefit use of these drugs. And lastly, it's being studied for Alzheimer's disease. So that would be a positive thing, of course, not a negative thing regarding cognition or change in dementia.
Thank you. Um, this gets switching gears about weight loss during taking the drug. If your weight loss level's off, would you increase the dose of the drug to get a better outcome?
Uh, in all of the trials, and of course, we only study a certain doses. But in all the trials where individuals are encouraged to either go to a maximum dose or we call maximal tolerated dose. That's how these trials are done. Weight plateaus or stabilizes generally after a year, year and a half or so. That's what it shows. We don't have really trials where they then go to even yet higher doses. We don't really have those trials. And as you saw from what I call these categorical plots or categorical figures, is that not everyone loses the same amount of body weight. Some lose less than average, some lose more than average. So you may, for a variety of reasons, your biology, your social circumstances, psychological, social profile, and so forth, may be losing less weight on average. And it may be that you may not be able to lose more weight, even going to a higher dose. And we don't understand what that is. My recommendation is to talk to your prescriber about and ask them, would I benefit from going to a higher dose?
Thanks. Um, the next question is about losing weight on these drugs. And do you do the drugs adversely affect one's muscles and joints, or how can you preserve your muscle mass and
Yeah,
strength?
Great question. You know, being involved in this field for 40 years, I thought I would never be in a situation where my patients are losing too much weight. I mean, it's just really remarkable. It's always how much can I help these people lose? We now have what we call super responders that are losing 25, 30% or more, which can be problematic. If I have a patient who is, let's say, 50 to 60 years old, who's already kind of losing muscle mass because of aging, and they lose 30% of their body weight, 25% or 30% is likely to be muscle. I'm very concerned. So we are now refocusing our attention on providing healthy lifestyle tips for all individuals who are taking these medications. And the key take home here is, of course, live a healthy life. It's not either or, it's and. You want to increase the amount of protein or make sure you're taking adequate amount of protein in your diet. And the number we use is about 1.2 to 1.3 grams per kilo per body weight. Now you have to do the math and figure out what that is, but that's what you want to write down and then do the math for yourself and convert that to how much protein you should be eating, roughly 80 to 100 grams of protein per day, probably something like that. That's number one. Number two, equally important, is to add resistance training in your exercise portfolio. Weightlifting, using bands, doing calisthenics, climbing stairs, carrying groceries. These are all kind of resistance training activities. You want to do that. So you want to take enough protein, which is the building block, and do the exercise to build it into muscle or hold on to your muscle. Those are two takeaway messages.
Thank you. Someone else has a question about, can you comment on the compounding agents and the compounds that are being offered on the online platforms?
Yeah, so compounded GLP-1s, everyone's heard of those. That's what all these telehealth commercial programs have been using to keep the costs down, by the way. That's in part why they're doing it, which are basically active ingredient is coming from outside the country, and they have a pharmacy that's making the recipe out of available information. So it's not the same product. You're not, if you want to take semaglutide or tirzepatide, you're not getting it with a drug that's compounded. I will tell you, however, compounded is now illegal. It is, FDA has actually banned compounded semaglutide and tirzepatide. So you're not going to find it anymore. If you are, they have changed it so much that they're not infringing on patent anymore. In other words, they've added something to it. I would caution you regarding taking a compounded product unless you really know what you're getting or your prescriber knows what it is.
Thank you. I'm trying to search for this question because you hit on it, but I try to say it from memory. So basically the two different drugs that you talked about with the different um, effectiveness, if there's a non-responder on one, would you switch them to the other to try to make them become one?
That's a great question, and those studies are being done in real world studies, and that is you can be a non-responder to Wegovy and then switch to Zepbound, which is the other one, and respond to that, and vice versa. So that is exactly what we do in clinical practice. If you don't respond to one GLP-1, it doesn't mean you won't respond to any. So it makes sense. If you have the ability to get it, cost and availability and access, try another one. You may respond to that.
Thank you. Well, we're about one more minute to our end, and we always want to respect people's time, especially yours, Dr. Kushner. Do you have one last statement you want to share with the group, but before we end this, that we
Well,
haven't covered?
I'll say that we're all, Northwestern is an academic institution. We're all doing research. These are pharmacological trials, but this research is done at our hospital and others. My particular interest is in helping train individuals to treat individuals living with obesity or with overweight, and that's where a lot of those funds go to.
Well, and since you brought that up, where I sit on the side of philanthropy and alumni relations and development, I know that the training of the next generation of leaders is really affected by philanthropy. So if anybody wants to help support our next generation leaders through fellowships or education scholarships, you'll have my information after this. But thank you so much, Dr. Kushner, for volunteering to do this. Thank you to our 250 participants that have been on this call. We greatly appreciate you learning with us and exploring this fascinating new landscape. Thanks, everyone. Goodbye.